Contraception. This is the use of methods and devices to prevent pregnancy. Welcome to Focus on Health, a show on all matters health, wellness, and lifestyle. I am your host, Joy Bofenda, and joining us today is Professor Anthony Wanyoro, an obstetrician and gynecologist who's taking us through hormonal and non-hormonal contraception. But before we dive into this very interesting conversation, take a look at the health updates. Welcome to Focus on Health, and like we said, we are having Professor Anthony Wanyoro, who's taking us through hormonal contraception. So, Daktari, kindly introduce yourself to the audience.
Well, my name is Professor Anthony Wanjoro. I'm an obstetrician gynecologist and an associate professor at Kenyatta University School of Medicine.
Okay, so what is hormonal contraception?
Well, hormonal contraception is part of an arsenal of methods that can be used to reduce the risk of a couple getting pregnant or for a couple to get a chance to get pregnant when they want. So there are different types of contraceptive methods. So hormonal contraceptive method is those methods that use hormones to manipulate the hypothalamus pituitary ovarian axis in order to prevent conception.
Okay, so maybe give us a broad overview of the types of hormonal contraception.
Well, there are many types of hormonal contraception, and you can look at them in different ways. Uh, you can look at them as at the mode of delivery, where you have from oral contraceptive method, subdermal contraceptive method, injectable contraceptive methods, or you can also look at them as long-term and short-term methods. So short-term methods are methods that many women will use on a day-to-day basis, like the oral contraceptive methods, which are divided into two. We have the progesterone-only methods and also combined oral contraceptive methods, or the pill, which is the commonest method. Of course, you also have the long-term methods, which include the injectables and also the implants.
Okay, so with your experience, is there a particular preference between non-hormonal and hormonal? Which one is better?
Well, the two broad, as you have said, methods. We have the non-hormonal, and of course, we also have the hormonal methods that we have discussed. We had talked about before. When you look at the non-hormonal methods, these are the methods that do not use a hormone. But there is no major preference. It all depends on an individual person and the conditions, other conditions that that person may have to decide on whether to use a hormonal or a non-hormonal contraceptive. But many people, of course, depending on their conditions, depending on the number of children they have, of course, they may opt to use a non-hormonal contraceptive method.
Okay, so when it comes to the choosing of the types of contraceptives, is there a guiding criteria people choose, or you just go with any?
Well, of course, there is a guiding criteria that is normally used when people are starting on a contraceptive methods. And the criteria usually is the criteria that has been given by the WHO, the World Health Organization. It is called a medical eligibility criteria. These are criteria that looks at the person's characteristic and also that person's medical or existing medical conditions. And it's a criteria that clinicians or healthcare providers will look at that person and decide on which is the best methods, looking at the conditions of that person, like the age, the previous history, obstetric history, the previous medical history, and then decide which is the best method for that person.
Okay, so maybe we can start with the most common people know, and that is the pill. How do they work?
Well, if you look at the pill, of course, we have two types of pills, which forms a major group of the hormonal contraceptive methods. So we have the progesterone and the progesterone plus estrogen containing methods. So for progesterone containing methods, the main mechanism of action is through the cervix. So what they do is that they weaken the cervical mucus so that there is a less likelihood of penetration of the spermatozoa or the sperm into the uterus. So they make the environment hostile for penetration of the spermatozoa. Of course, there are other minor mechanisms when you're looking at progesterone only, which is the thinning of the endometrium lining. The endometrium is the inner lining of the uterus where the egg is supposed to be implanted. So when this becomes thin, then there is less likelihood of the egg being implanted. Of course, we also have the combined methods which contain the progesterone and estrogen. So the estrogen component, it increases the chance of, it increases the contraceptive effect because estrogen itself will interrupt ovulation. So unlike the progesterone only methods, so when there is a combined method, so we have cervical mucus effect. We also have thinning of the endometrium. We have reduction on the movement of the fertilized egg toward the uterus, and we also have interruption of the ovulation.
So, with all these mechanisms of action, are there any side effects that come along with it?
Of course, there is no method, that contains a hormone that does not come with side effect. But the side effect, you look at it on the depending on what the content of the method itself. The fewest side effects is usually on the progesterone only methods, uh, but the estrogen containing methods have major side effects in some women. Of course, the worst that are feared is when you have clotting of blood within the blood vessels with the risk of those clots going into the lungs in a process called thromboembolism. We have also an increased risk of diseases becoming worse. Like if you give combined contraceptive method people with hypertension, you may get severe hypertension. If you give combined contraceptive method to people who are heavy smokers or people who have risk of stroke, then you may end up with a stroke or with an ischemic heart disease. But in all, the majority of the side effects are minor, like things like acne, mood changes. You may also get a bit of discomfort in the breast. Some people may complain of spotting occasionally, but these are basically minor side effects. But the major ones, of course, are the ones that are feared.
Okay, so there's also this misconception. I don't know if it's a misconception that using of hormonal contraceptives is linked to cancer. How true is this?
I think this is really a misconception because when you look at it, when you use combined contraceptive methods, and especially when you interrupt the hypothalamo pituitary ovarian axis, then you may protect some women against some cancers, especially cancer of the ovary and the cancer of the inner lining of the uterus, which is the endometrium. So because these two cancers depends on the on ovulation, then when there is fewer ovulatory cycles, then you protect women against these two cancers. However, in women who are at risk of breast cancer, then when you use an estrogen containing method, then there is a slight increase in such women. And this is what the WHO medical eligibility criteria comes in, so that you look at the existing conditions and the risk to this woman, so that you give the right contraceptive method.
Okay, so you can also mention the fertility concerns after ceasing using this combined methods.
Well, for the hormonal contraceptive methods, especially the combined method, remember we are interrupting ovulation. Uh, what we know is that when you stop the method, then the time of stopping the method to conception is usually very short. And that's why women are supposed to take, if it is the combined contraceptive method, they are supposed to take a pill every day for 21 days. Then they will rest for 7 days. If it is the progesterone only pill, then they are supposed to take it for the whole time. But what is known is that the lag between stopping the pill to conceiving, it's about less than 3 months. So the disruption, or after that, any reduction in fertility is not related to the method that that person was using. Maybe it could be because of other problems that that person may have acquired.
Okay, so what if someone misses a pill accidentally?
Well, in an ideal situation, people should not miss their pills. They should take the pill at the same time every day. If it is the progesterone only, they should take continuously until normally progesterone only pills are taken when women are breastfeeding and the babies are less than 6 months. After 6 months, because they don't disrupt ovulation, so what we know is that most women after 6 months after delivery, they will have an increase in the ovulatory cycle because there is a reduction in breastfeeding and the prolactin has also reduced in such women. So they are supposed to take, like if they are supposed to taking the progesterone only pill, they start from 6 weeks after delivery to 6 months. And they are supposed to take it daily.
Very interesting conversation we've just had, but we are taking a short commercial break. We'll be right back. Do not touch the dial, but before then, take a look at the Did You Know segment. Welcome back to Focus on Health, and like we said, we are discussing hormonal contraceptives alongside Professor Anthony Wanyoro. Take a look. Okay, so Dr. also mentioned who is not supposed to take the combined contraceptions.
Well, when you look at the criteria that is used to initiate or to start contraceptive methods, the criteria start from 1 all the way to 4. Mm-hmm. So when you look at category 1, this means that anybody can use that method. When you look at category 2, it means that there is some small risk, theoretical risk, but the advantages of using that method are usually higher than the risk. When you look at category 3, what it means that the risks are much higher and you need to follow up that patient properly. When you look at category 4, it means there is absolute contraindication for that method. So when you look at something like the combined pill, which you have said contains the estrogen and progesterone, women who are in category 4 are women like women who have had DVT or thromboembolism, okay, or women with severe hypertension, women who are elderly and they are smokers, or women who are at risk of either stroke or ischemic heart disease, or women who have had stroke, women with multiple valvular disorders, etc. So those are people that you will say these women, they should not be use any hormonal containing method.
Okay, so there's also a lot of buzz concerning Depo-Provera. Maybe you can start by describing what exactly is Depo-Provera.
Well, Depo-Provera is another method that is currently one of the commonest used method in our country. It is usually an injectable method that contains progesterone only. And Depo-Provera is women are injected with Depo-Provera once every 3 months. So why it is liked in our country and in most of the African countries is because of the ease of administration and the fact that it is a long-term method and there is more privacy in this type of method.
Okay, so also there's a lot of fertility concerns. People are saying that if you take Depo-Provera, especially if you're unmarried and you want kids later on, you're going to struggle getting fertile again. Is this true?
I would say this is one of the myths. Remember what we said is that something like Depo-Provera should be given, women should be injected once every 3 months. So if they are not injected, they delay the injection, then they are likely to get pregnant. Because remember what we have said is that a method will only work when that person is on that method. So the issues of fertility concern, infertility, it depends on why did that person get a contraceptive method. Because of course some people may use contraceptive methods and then they are more sexually active or they have multiple sexual partners. So if a person is using that method and they are having multiple sexual partners, then they run the risk of getting infections and then these infections will lead to tubal blockage and they end up with an infertility. So it is not the method itself that will give that person, will make that person have difficulty in conceiving. It is the intention that that person had to start a contraceptive method.
Okay. Also, there's a concern with issues such as bone density, cancer when using Depo-Provera. Kindly explain to us those things.
Well, remember, when you look at something like Depo-Provera, uh, of course, a few people, because of the depot itself, it will interrupt a bit of the hypothalamus pituitary axis. And when you reduce the amount of estrogen with the endogenous estrogen within the system, or the estrogen that is produced when the hypothalamus pituitary ovarian axis is working, then you may reduce the bone density. But the Depo-Provera itself may have very little effect because its effect on ovulation is not as much as estrogen containing methods. Of course, there has been a bit of concern with Depo-Provera and its role in cancer, especially in cervical cancer. But Depo-Provera itself does not cause cancer. What happens is that when you are using Depo-Provera, as we have said, a person may have the wrong intention, have multiple sexual partners, and then they may acquire human papillomavirus. And because of the effect of the progesterone within the cervix itself, then you may find that there is persistence of that human papillomavirus within the cervical cells itself. Then cancer, carcinogenesis may start. But it is not the depo itself that gives you the cancer. Yes.
Okay, so maybe we can jump into implants very quickly. What are the types of implants, and maybe give us their efficacy and how long should we use them?
Okay, so implants are methods that are also long-term but still reversible. Implants contains progesterone called levonorgestrel. So, and depending on the amount of that progesterone, then we may have implants that will last for 3 years, which is a single rod that is implanted under the skin, or you have implants that will last for 5 years, which contains currently 2 rods. Okay. The main mechanism of action is, as I had said, because they still contain progesterone. So the main mechanism of action is through the cervical mucus, making it more thicker and more hostile, and then, of course, thinning of the endometrium.
Okay, is there also a risk of it dislodging and moving to the lungs or something like that?
And no, that one categorically is a no. Of course, remember, for something to move into the lungs, then you need to have implanted it into a blood vessel. And if you are to implant it into a blood vessel, of course, the first thing that will happen is that the patient will bleed a lot. So the implant, normally we just put it just under the skin. So there is no risk of it moving from one area to another one. Yes.
Okay, so let's also discuss emergency contraception. So how exactly does the main drug being used in Kenya is postinatal? How does it work?
Emergency contraception is emergency. Of course, there is a misconception that people have had about emergency contraception, and an emergency is an emergency. Unfortunately, people plan their things and then they decide not to use a contraception and they say there was an emergency. So emergencies are contraceptive methods. The concept of this was brought in because of issues where a woman's intention was not to get pregnant, but for some reason that were beyond her, she had sexual intercourse. So there are different types of emergency contraception that can be used. So we have hormonal emergency contraception and non-hormonal emergency contraception. So postnatal 2, which is the commonest used method, is a hormonal contraceptive methods. But for hormonal emergency contraceptive methods, in an ideal situation, they should be used before a woman ovulates. Because the main mechanism for hormonal emergency contraception method is to flood the ovary with a lot of hormone so that ovulation is impeded. But when taken after ovulation, then their effect is not very good. And this is what brings the problem with emergency contraception. Another good emergency contraceptive method is inserting the IUD, the intrauterine contraceptive device, that can be used even after ovulation has happened.
Okay. So when using emergency contraception, especially the hormonal ones, how many times should a person use it in a year? Because at this rate, people are abusing it.
Well, what we have said is that the hormonal emergency contraceptive methods is a method that contains a high amount of hormone, and that is where the risk comes in. Of course, unless if there is an emergency, no woman should use an emergency contraceptive method. Okay, but of course, we say that any woman who is using emergency contraceptive method is a woman who has a contraceptive need. And what we should do is that we should try to put this woman into a regular contraceptive method so that she does not put herself at risk of increased risk of taking a lot of hormone at the same time. When you take a lot of hormone, like the emergency contraceptive method, one of the major risks is that you may have thromboembolic phenomena. Two, you disrupt the cycle because you are flooding the ovary with a lot of hormones. Then at one time or the other, you will get pregnant because its effect is not as good as the taking a normal contraceptive method. And when you get pregnant, of course, you have an unwanted pregnancy. If you are lucky, it will be intrauterine. But in quite a number of patients, you get an extrauterine pregnancy because that emergency contraceptive method.
Okay, so Dr. Is there anything I have missed in relation to hormonal contraception that you would love us to know?
Well, I think you have covered most of them. But of course, when you look at it, we say that hormonal contraception methods are good, but they should be initiated after a proper history and clinical evaluation of the patient, so that you put that woman in the correct medical eligibility criteria to reduce the risk that those hormones may have on that mother.
Okay, so Dr. Does that mean that you cannot self-medicate in terms of contraception?
Well, I know, of course, people have self-medicated, but the initiation of hormonal contraceptive method would be best done by a clinician or a healthcare provider with some bit of knowledge on the medical eligibility criteria, so that you can be able to put that person into those four criteria and decide which method is safest for that person in order to reduce the risks to the women.
Okay. Very interesting conversation we've just had. And just as Professor Anthony Wanyoro has emphasized, do not self-medicate when initiating contraceptives. I have been your host, Joy Bofenda. And until next time, stay safe, stay healthy, and live with the Healthy You segment.